Okay, good evening, ladies and gentlemen. Thank you very much for joining us this evening. We're back for another segment of Cancer and I, and this is what we're doing in line with World Cancer Day, which happened on the 4th of February. Kita raya pun 1 bulan lah. So World Cancer Day pun boleh 1 bulan lah. So we're continuing on with the next segment of Cancer and I, and this evening we're very privileged. We're going, I think we have a very interestingly sounding title, Seeing South. So we're actually going down south. It's actually a play. So we're going south in two ways. Going south both in terms of geography, because we're very fortunate to have three very eminent experts with us from Hospital Pantai in Malacca. But we're also going south in terms of the body's geography. So today we're talking about the lower regions a little bit, so about the colorectal and ovarian cancers. And I'm very privileged this evening to first of all introduce the first speaker for this evening, who is a consultant clinical oncologist and a very good friend of National Cancer Society of Malaysia. Actually, I'm lying. Actually, all three of them are very good friends of National Cancer Society Malaysia in the Malacca branch. But we're especially we're close to Dr. Daniel, who is our medical advisor for the Malacca State branch of NCSM. So this is basically a teh tarik session of old friends minus the teh tarik. And we're very pleased that Dr. Daniel will be with us this evening, and he will speak to us about challenges of late-stage colorectal and ovarian cancers, two very kind of prominent cancers that we are going to speak about today. He's going to be accompanied by two other very eminent gentlemen in their own fields who will also kind of round up this story and give us a very southern perspective. So, Doctor, good evening. Thank you very much for joining us. And first and foremost, always the killer question that I seem to be asking everybody: why oncology? But I've got an additional question for you, which is why Malacca? Are you from Malacca, Doctor?
No, I'm actually from Petaling Jaya, but I've been living in Malacca for the last 10 years now, working in Pantai Aigro. My wife is from Malacca, so that's why I'm here.
Okay. Also, the in-laws brought you over lah.
Yeah.
Yeah. So, but why oncology, Doctor? How did you venture into oncology? Why did you decide to become oncologist?
This was back in 2001, 2002, when I finished my senior house officer training in the UK, and deciding on what to specialize in. I knew it was going to be something in the medical field rather than the surgical field. And at that time, Malaysia was extremely short of oncologists as it is today, but far shorter at that time. And it also happened to be at that time, the UK was also short of oncologists compared to the rest of Europe. So there were a lot of training positions that came up. And I think I was fortunate enough to apply and to get into a training position. So opportunity, I guess, and also the need for oncologists in Malaysia. I guess even though I was in the UK for a bit by then, but I've always had the heart to return to Malaysia.
Right. Lovely. Thank you so much, Doctor, for, of course, coming back for one and really keeping the flag flying in other regions other than KL. Very often, there's very few of us who are in the other areas serving the communities there. Doctor, so really, this evening we're speaking about late-stage cancers, in particular about colorectal and ovarian cancers. And, you know, I'm sure you manage many of these cases, and we'd really like to get some insights from you on these two particular types of cancers manifesting the late stages. With all due respect, please allow me to turn the stage over to you, Doctor. Thank you very much.
Thank you, Murali. Thank you. Let me just share my slides quickly. Right. So good evening, ladies and gentlemen, those of you who are joining us on Zoom. It's a pleasure for me to share with you something about late-stage colorectal cancer and ovarian cancer. Let me just say a few words of introduction about this topic in general, then share a bit about the challenges in late-stage cancer and then talk about new therapeutic options. What are the latest treatment available for these cancers in the late stages? I'm not sure whether you know, but there are 4 stages in cancer staging: stage 1, 2, 3, and 4. Stage 1 and 2 are considered early cancers. Stage 3 and 4 are later stage cancers, particularly stage 4 cancers, which is the later stage, where the cancer usually has spread to other organs. Look at the CRC, or colorectal cancer. We shorten it to CRC. It's the second most cancer overall in Malaysia, with the incidence of 13.6%, according to GlobalCan in 2020. And if you look at the NCR, our National Cancer Registry, based on 2011 to 2016, 40% of patients present with stage 4 disease, the most advanced stage. And if you look at it in the context of stage 3 disease, it's 33%. So in total, the later stage presentation is 73%, almost 3/4 of patients present in the later stages. And I just want you to take note that the 5-year survival rate for stage 3 disease is about 60%. As far as ovarian cancer is concerned, it's the 3rd most common cancer among females. 7.2% of female cancers are ovarian cancers. And thankfully, there are fewer patients who present with stage 4 disease, only 26%. But 31%, still substantial proportion, present with stage 3 disease, which is the next lower stage. But if you notice the difference between ovarian cancer and colorectal cancer is this, that in ovarian cancer, despite the fact that there is one stage lower, stage 3 disease, you can see there's a significant difference between the proportion of patients who live for 5 years beyond the diagnosis compared to colorectal cancer. Colorectal cancer much better with stage 3 disease, 60%, while in ovarian cancer, it's lower. Sadly, I'm going to focus here on stage 4 disease, and I guess that includes those more advanced, the bigger stage 3 disease. A vast majority of patients are sadly incurable. And the focus of our treatment is basically palliation. And palliation essentially means prolongation of life and maintaining quality of life by controlling the symptoms the patient may have. Of course, the holy grail as far as therapy is concerned, even in advanced disease, is what we call personalized treatment, which I'll share with you shortly. Basically, we want treatment that is super effective, controls the cancer for a long period of time, even if it's not curable at the end. And we also want treatment that has 0 side effects, where the patient can get on with life and nobody knows that they're having anti-cancer treatment. Today, for my talk, as far as the advanced cancer stages is concerned, I'm going to focus on non-surgical options, and my 2 colleagues, Dr. Arvind and Dr. Schenker, will share with you some of the surgical options available. So what are the challenges in managing late-stage colorectal cancer and ovarian cancers? And I guess that applies to late-stage stage 3 cancers as well as stage 4 cancers. So it comes in 2 ways: either patients who have symptoms for a long time and they present late. So they've been suffering, they've been having problems with passing motion, abdominal pains, abdominal bloating and discomfort, or they have had bleeds and so on. They turn up late because they are frightened, they are fearful. Versus, of course, those who have been diagnosed with earlier stage cancer, maybe stage 1 and 2 cancer before, but it recurs. So it can come in 2 ways. The trouble is when a patient comes, especially when they come in the late stages without any previous follow-up, they can be in poor general condition. So they're tired, they're weak, they may be in pain, they may be vomiting if there's obstruction of the bowel, and certainly their appetite will be poor and they would have lost weight. And a lot of them come with anemia. They have low red blood cell counts, and so they can be very weak and breathless because of that, and a significant proportion will need a blood transfusion. Some of them, depending on where the cancer is at and how extensive it is, can have impaired kidney function. So kidney is not working well, and the liver can be affected as well because of this late stage cancer. The other problem I find that is the tempo of disease. So at this late stage, by the time the patient comes, it basically means they are experiencing issues, symptoms from the cancer. And at this stage of the cancer, the the volume of disease, the amount of cancer in the body is a fair bit compared to what it was when several months prior to that, when the symptoms were mild. So by this stage, generally speaking, the disease is developing at a fairly fast pace. The other problems, of course, is we have to, as patients come in, we're going to look at their coexisting medical problems as well. Do they have diabetes? Do they have other coexisting kidney problems, high blood pressure, heart problems, and so on, which of course may affect the decisions that we make regarding treatment. The other thing that you'll see that from clinical research is as cancers develop into later stages, they develop, the reason why it spreads and the patient becomes unwell is because the cancers develop more and more mutations in the genes. So there's a greater mutational burden, which means the cancer can become more difficult to treat, more resistant to treatment, because there are more and more mutations, which causes it to be more aggressive. And what I'll tell you, I'll share with you later about molecular profiling. And these are tests that we actually send off to either KL usually or overseas sometimes to actually test the genetic mutation or to examine, to investigate the presence of certain proteins which will help us to decide on the best treatment for the patients. And generally speaking, depending on where we send it, it takes 1 to 3 weeks. So cancer is developing quite quickly, and we need about 1 to 3 weeks before the results come back. It's a bit of a dilemma as to what is the most appropriate treatment at times. Now, of course, constantly at the back of our minds, as for clinicians, as doctors, as well as, I guess, the patients who are seeing us for the first time, as well as relatives, caregivers, the question is, will the patient be able to tolerate the anti-cancer treatment that's being proposed? And if they're able to tolerate it, then to actually benefit from the effectiveness of the cancer treatment. So that's a big thing because they're coming at a late stage. They may be unwell. They may have other medical problems. The cancer may be going very quickly. So we don't have a lot of time to actually assess and start the treatment. Now, let me just give you this picture, this cartoon of what we hope to do, what we're doing now a bit, and also what we're going to do more and more in the future. It's called personalized medicine or precision medicine, where we tailor treatment according to the precise nature of an individual's cancer. I want you to concentrate on the pictures, the diagram on the left side. And this is how we used to treat patients in the past and to a certain extent in the present as well. So imagine we're talking about colon cancer. So we have a group of, let's say, 6 patients with colon cancers. In the past and to a certain extent in the present, we assume that they're exactly the same, although we have discovered that they're really not the same because the nature of individual cancers, despite the fact that they are all in the colon, can be different. So in the past, we have given them the same treatment. So in this case, it's a green color pill, same treatment for all these 6 patients, right? But you look at the bottom, the results of the treatment from one treatment fits all, we just use a green tablet for all. Those patients which have a green type of cancer will benefit from the treatment. Those with partially green and something, and then partially some other color, have not a very good effect. But those who don't have any green in the cancer, they just get all the side effects, with very little benefit from the treatment. So you can see if we consider all cancers the same type of cancers, if we think of it as the same and give it one treatment, there will be that substantial portion of patients who don't derive any benefits, and worse still, some who get all the side effects, but with absolutely no benefit, right? Now, on the right side, we see the medicine, somewhat of the present, but certainly in the future, there's more personal tailoring of treatment. So we recognize that cancer patients, for example, colon cancer, are different. Although it's all colon cancer, it's all within the anatomy of the colon. We use blood or DNA samples, urine, tissue to analyze, and we use very sophisticated biomarkers of proteins to examine proteins within these tissues. And we divide patients into the subtypes. So we divide them into green, all green. We divide them into green plus some other colors, and we divide them into just blue without any green within it. And for each of these, we give a treatment that's specific for that subgroup of colon cancer patients. And what happens is, because they're being given the appropriate treatment, all of them benefit from the treatment. That's tailored treatment or personalized medicine that we are all aiming to achieve in cancer care. And certainly that applies to advanced cancer as well. Let me share with you now some new therapeutic options for advanced colorectal cancer. One of the main groups in the last few years that have been added on to chemotherapy. So chemotherapy is still being used, but we add certain treatment onto it, which makes it even more effective. And these are so-called anti-angiogenics. Angiogenics means the formation of blood vessels. And all cancers, as it grows, requires blood vessels to supply blood to the cancer as it grows so that it gets sufficient nutrition and oxygen. What happens is as the cancer grows, lots of blood vessels get there. And if you give any of these angiogenics like bevacizumab, ramucirumab, aflibercept, or regorafenib, which is usually given which is a tablet, if we give any of these treatment, it can damage and block off the blood vessels, reduce the blood vessels to the cancer. So if you reduce the blood supply to the cancers, then the cancer cells will die off even more effectively if you combine it together with chemotherapy agents. There's another group of treatment called anti-EGFR monoclonal antibodies. These are injected drugs. These are given as a drip. EGFR stands for epidermal growth factor receptor, which causes, is a protein growth pathway which causes cancer to grow. For certain cancers which does not have this protein or does not have this mutation called RAS, it does not have BRAF mutation. So two different types of mutation, which is WT stands for wild type. If these mutations are wild type, there is no, if these genes does not have a mutation and it's on the left side of the colon, you can use these two drugs called cetuximab or panitumumab. And if you add it on to chemotherapy, and sometimes when you use it alone, it can be very effective in controlling the cancer because it blocks the pathway for growth to happen. But it generally works only on the left side of the colon. So look at this picture in the sigmoid colon, the rectum, and the descending colon, where it works well. But if you go onto the left side, if you go on the left, the right side of the transverse colon, the ascending colon, this drug doesn't work as well. You might have heard of this new group of treatment called immunotherapy, which is meant to strengthen the immune system against cancer cells. Well, there are two drugs that are used for advanced colorectal cancer in the stage 4 setting, pembrolizumab and nivolumab. It's only suitable for about 15% of patients with advanced colorectal cancer. We have to test the actual cancer. Remember, we said that we want a personalized treatment. Only about 15% will benefit from this, not everybody. So patients need to understand this. So the doctor is responsible for getting the samples of the colon cancer, send it for testing, and this MSI stands for microsatellite instability, and the H stands for high. And generally speaking, those with microsatellite instability, high tumors are tumors which have a high degree of genetic instability, and we also call it DMMR, or deficient in mismatch repair. So in this kind of cancers, certainly immunotherapy can be helpful and effective, but only in 15%. So let me explain to you, in the immunotherapy, people have been interested in it for a good part of the last 100 years. It sounds very good, isn't it, to say we want to harness our immune system, we want to strengthen our immune system against the cancer. So the latest form of immunotherapy is called immune checkpoint inhibition. If you look at these two pictures that I put up about the latest form of immunotherapy, and pembrolizumab and nivolumab, these two drugs which I mentioned before, are part of this. Has this certain mechanism. So if you look at the tumor cells on top, on the left side, it's in yellow color, and the T cell, which is the immune cell, which is supposed to fight against the cancer, is in blue. Now, the T cell, which is the immune cell, can recognize the tumor cell because on the surface of the T cell, there's a T cell receptor protein, which can recognize a protein on the tumor cells called the antigen. You can see that there. But there is also another connection between the T cell and the tumor cell, as you can see, and is the PD-1 protein on the surface of the T cell, which is in contact with PD-L1 protein on the surface of the tumor cells. Now, The T cell can recognize the tumor cell, and it's supposed to recognize that it's a bad cell, it's a foreign cell that you should destroy. The problem is, once the tumor cells is very clever when it produces the protein PD-L1 on its surface, it shakes hands with the PD-1 protein on the tumor cell. And the moment a handshake occurs, the interaction between PD-L1 and PD-1 proteins, immediately the T cell does not consider the tumor cell a bad cell. So it sort of makes friends like by shaking hands. And look at the right-hand picture. What happens is these new treatments, which are what we call monoclonal antibodies, which block the immune checkpoint, it inhibits it. You can either block the protein on the PD-L1 site, or you can block the protein on the PD-1 site. So you can see the red color one or the yellow color drug. Either way, as long as the handshake is broken, suddenly the T cell wakes up, it says, oh, I can recognize this tumor cell, and it begins to exert an anti-cancer effect. You can see on the right-hand picture, the tumor cells die as the T cell kills it off. All right. So that's how this immune checkpoint inhibition works, and that's the latest form of immunotherapy. All right. It causes the T cell to be active and no longer make friends with the tumor cells. There are other new drugs like this. Fluoropyrimidines is actually a form of chemotherapy we've used for a long time. This TAS-102 is something that is new. It's only come into the market, I guess about 4 or 5 years. And that's because it has a unique mechanism that this TAS-102 is a combination of two drugs. Trifluridine is the actual chemotherapy agent, but it's joined to TP-Racil. And TP-Racil stops the enzymes from breaking down trifluridine. So normally when drugs get into our system, it's broken down by the enzymes in our body to make it into harmless substances. But TP-Racil prevents the enzymes from breaking down, so you get higher levels of these chemotherapy trifluridine, which kills off cancer cells. There's a new drug called NTRK inhibitors, and two examples of it is larotrectinib and entrectinib. Okay, these drugs are available but not yet licensed in Malaysia as yet. It can help a small number of patients. Notice here that NTRK gene fusion, the one that with this specific mutation, is less than 1% of advanced colorectal cancer. But if it's used appropriately in this small number of patients, 60 to 70% of patients will benefit from it. They will find the tumor shrinking in a dramatic way. So worth doing, but only in a small number of patients that need to be tested for this. How does it work, this NTRK? Well, we need to test for this gene fusion. We see on this picture on the left side, the NTRK gene is a growth signaling gene. Okay, it causes cells to grow. What happens if it's alone? It grows cells grow normally. What happens is there is a mutation, it gets fused or joined to another gene. So when NTRK gene is joined to another gene, it produces a fusion protein, a protein which is not TRK alone, it's a TRK plus something else. And when you do that, if you see on the right-hand column, at the top, there is this cell surface that represents the two layers up here, represents a cell surface. What happens? The TRK A, TRK B, and TRK C are proteins at the surface of the cell. And if you combine it, if you fuse it with something else, it becomes very, very active. It doesn't depend on outside signals to grow. It keeps on causing the cells to grow. The signal is constantly on. And if you put an NTRK inhibitor like larotrectinib, like I mentioned before, the cells stop growing just like that. So it can be very effective, and that's how it works. Trastuzumab, pertuzumab, and lapatinib, you may have heard of it as drugs that we use for breast cancer. Recently, we found that the same protein, HER2 protein, which is present on breast cancer, is found in colorectal cancer, the surface of colorectal cancer. And if they don't have any mutations in the RAS gene or the BRAF gene, then we can use drugs that are normally used for breast cancer. We can also use in colorectal cancer. But again, that's only small numbers, 5 to 10%. This is the latest stuff that we have. encorafenib, again, is not yet licensed in Malaysia, but available overseas. Cetuximab, we have mentioned, is an anti-EGFR. And benimetinib is what we call MEK inhibitor, another new drug. So we got a lot of really new drugs. Some of them, encorafenib is a tablet, benimetinib is a tablet, cetuximab injectable drip, and it's only useful for BRAF mutation. So if this mutation B600E is present, a very specific mutation we only see in 10% of metastatic colorectal cancer. If you use these drugs in a specific setting, it can benefit a substantial portion of patients. Just want to mention this as a aside, because we talk a lot about what we call medical oncology. We use drugs or either tablets or drip injectable agents, but there's also what we call ablative therapy. So if the cancer spreads to a small number of spots in the liver, you can actually do something to improve the outcome, to improve the cure rate, or improve the time the patient lives. So we can do surgery to remove such cancers, or we can do this RFA, radiofrequency ablation, where we put a needle in and use heating probe, we put it in and use radiofrequency to heat up the cancer and kill off the cancers. Or we can use chemotherapy via the blood vessel. We can put via a specific blood vessel to the tumor. We can use SIRT, selective internal radiation therapy. We can put radioactive substance right into the blood vessels that supply the cancer, kill it off. Or we can use highly focused radiotherapy, stereotactic body radiotherapy. So it's not just drip or tablets which goes through the whole system. We can also use local treatment into areas like liver specifically, and sometimes lung if there's just a small number of them. And certainly we have seen good outcomes from that. We'll quickly move over to ovarian cancers now, and I'll focus on epithelial ovarian cancers. I'm sure Dr. Arvind will quickly explain to you later. If you look at the right-hand picture, it is a picture of an ovary, and the 95% of cancers appear on the surface of ovaries, okay? 95% of cancers. There are other cancers inside, we call germ cell tumors or sex cord stromal tumors, which is rare, all right? So we have a range of cancers from the more common ones, high-grade serous and endometrioid, to the less common ones below. Now, so in the last few years, there have been new drugs which we can add on to the standard chemotherapy that we've had. And then, as I mentioned before, there's this anti-angiogenic called bevacizumab. So it's been good for colorectal cancer, but now also used for ovarian cancers. It can control cancer for a longer period of time, but it's not necessarily curative. All right. And there's another drug called pazopanib, which normally we use for kidney cancer, but it's also been found to be useful for for ovarian cancers, and that's a tablet form. The other thing we have found is if BRCA1 and 2 mutations, if patient have this particular mutation, you may know that Angelina Jolie, a few years ago, had a bilateral mastectomy. She had both breasts removed and ovaries removed because she had this tumor, this mutation, because this mutation just increases a cluster of cancers, including ovarian and breast cancers. But for ovarian cancers, if they're high-grade serous or endometrioid cancers, worth testing for this mutation, because if these mutations are present, then this group of drugs called PARP inhibitors, which inhibits a certain enzyme can be very useful. And two of these drugs are called olaparib and niraparib. Olaparib is already available in Malaysia, it's licensed here. Niraparib not at the present. Let me just tell you just very briefly about how PARP inhibition works. And that's the great thing about how research in the lab actually is translated to what we do in the clinic, okay? So scientists very cleverly have discovered that there is this enzyme called PARP, P-A-R-P, which actually repairs DNA breaks. So if there's a break, there's a damage, any damage or mutations to DNA, it can repair it, okay? And the cells can survive. That's a picture on the left-hand side. On the right-hand side, if the patient has a BRCA1 mutation, you see it down below, they already have the cancer cells have already a problem with a separate DNA repair pathway. They already have difficulties repairing the genes. So what happens if we use PARP inhibitors in patients with BRCA1 or 2 mutations? when the PARP is inhibited, we stop it from repairing what we call single-stranded DNA break. These single-stranded breaks cannot be repaired, and it gets translated to a double-stranded break. So you don't repair a single-strand break in the genetic material, it can easily be converted to a double-stranded break. And a double-stranded break is more difficult to repair. PARP cannot repair it any longer. And if the cells are normal, if there are no BRCA1 or 2 mutations, if the homologous recombination repair pathway, which is for non-BRCA1 mutations people, is easily repaired. But double-stranded break is not repaired in patients with BRCA1 or 2 mutations, and that's where the cancers experience apoptosis or cell death. So PARP inhibition is a very specific, very unique pathway by which we can actually target cancer cells in certain groups of patients that can be very effective. But it doesn't work very well in patients who do not have this mutation. Okay, for ovarian cancers as well, there is immunotherapy. We can use it in about 8 to 12% of patients, like very much like colorectal cancer. And also NTRK inhibitor, which I mentioned before. This is really fine print, but there's a small number of patients with a rare NTRK gene fusion, which again causes cell to grow abnormally. Okay, just in summary, so we're talking about 2 very common cancer in Malaysia. Sadly, a significant proportion present late. They present either with late stage 3 disease or already stage 4 disease. We've seen that patients are very unwell, cancer's growing very, very quickly. They have to make decisions quickly about treatment and get the treatment started. And certainly in 2021, we want to do molecular profiling. I think it's essential. I think it should be done wherever possible to detect the mutations that I briefly mentioned earlier, so that we can practice as much as we can personalized medicine, that we don't use treatment that don't work. And I briefly also mentioned to you various new drugs, anti-angiogenic drugs, which damage blood vessels and shrink tumors, as well as immunotherapy agents, which strengthen the immune system against cancer. Okay, Dr. Murali, time for questions or comments.
Yes, thank you so much, Doctor. I think that was really a very thorough run through of all the modalities that are now available, Doctor, for late stage treatment. I was going to ask you a question. There's already a couple of questions, but I was just going to put forward a question to you to kind of maybe help people understand a little better. Okay, in terms of when you come with a diagnosis, and usually there's a biopsy done in the case of colorectal cancer, ovarian cancer. When you speak about molecular profiling, Doctor, what does this entail? What do they need to do?
Okay, there are a few things we can do depending on whether, for example, for most cases, we are actually taking the samples of tissue either via a biopsy or after the operation has been done. So in many patients, as surgery has been done, so we have a big piece of tissue, maybe about, not big, but maybe about 3 or 4 centimeters of tissue, which are removed, and it is sent off to the lab for sophisticated testing at the genetic level. So that's tissue, all right? So the other thing we can do nowadays, there's a newer way, and of course, this using tissue, we have been using tumor tissue for many years. What's new in the last, I guess, about 2-3 years has been what we call liquid biopsy. So what happens is cancer cells in the body break down all the time. So the cells break down and they shed the genetic material or DNA within the bloodstream. So if I were to take a blood sample from a patient, and that's what we call liquid biopsy, there's no physical tissue. What happens, we have sophisticated systems where it can pick up genetic material shed by the cancer cells into the blood system, and we can detect gene mutations as well. The other way of doing it is, of course, for testing blood samples for genetic mutations that is already in the that is what we call germline mutation that is inherited from one generation to another. So tissue diagnosis, liquid biopsy, and also blood testing for something inherited from one generation to another, like BRCA mutation.
Right, Doctor. And another question that kind of comes up immediately is then you showed us quite a few different types of mutations. And so when you run this molecular kind of testing, do they test for all these mutations at one go? Do they do it in sequence? Have you got a certain kind of order that you do it in?
Okay, so depending on the okay, so a lot of it sadly depends on finances. Now, so there is so if we're looking for bang for buck, we normally do the test where maybe about 20 or 10, 20, 30% of patients have it. If it's only 1% or less, we might not do the test. So if we do the common ones like RAS, KRAS mutation, NRAS, BRAF, or HER2, we normally would do that. Okay, that's called a basic set of tests. But if you want to go for the full, what we call nowadays with the full molecular profile, one of them is called next generation sequencing, and that one goes through all the maybe about up to there's a set for 45 genes, another set for 100 genes, 200 genes, 300 genes. So there's a huge number of genes that the machine can actually test. So really sophisticated testing. So from basic genes, maybe about 5 or 6 mutations, the most common ones, to the very minute ones, which can test about 300-400 genes. Yeah, so there are different packages available.
Right. Lovely, Doctor. Doctor, there's a question on, and I think this, the very complex questions. There's one on colorectal cancer, HER2 positive in stage 4. It's a stage 4 patient. Is antibody drug conjugation of any use? I think it would be helpful if you kind of told the rest of us what antibody drug conjugation is.
Okay, there's this drug called trastuzumab deruxtecan, which also is used in this. Okay, now the thing is this. So, for example, we have cancer. So, if we have colorectal cancer, on the surface there are HER2 protein. So HER2 is what we call HER2 amplified colorectal cancer. So if let's say we have loads of this protein on the surface of the colorectal cancer, it basically means we can target this protein because this protein will not be present on non-cancer cells. All right, so it's a targeted treatment. So what happens is in order to target this, we need something that binds to the protein. So that's called the antibody. So antibody is something is in itself a protein, but it can recognize the HER2 protein on the surface of the cancer cells. And what you do is you attach onto this antibody some sort of anti-cancer drug. Okay, so you can use a chemotherapy agent or some. So it's what you call antibody conjugate is an antibody that just is a targeting agent. It's like a heat-seeking missile, but the actual bomb that is attached to the heat-seeking missile is actually carried along by the drug called by the antibody. So, for example, one of the other drugs which I did mention earlier, there's this drug called trastuzumab, which I mentioned earlier. In itself, it can be useful as a monoclonal antibody, but you can also double it up as a heat-seeking missile, and you attach a big bomb at the end of it. And deruxtecan is one of them. So you can attach the new research coming out all the time. In terms of, we have one drug which targets the surface proteins of the cancer cells, and you attach the bomb. So the moment the antibody brings the chemotherapy agent to the cells, it explodes as it were. So it kills off the cancer cell.
Right. And in colorectal cancer, is there a role for this?
It's coming more and more. It's coming more and more into it. Like in breast cancer, there are various research into this as well. So none of the drugs at the moment licensed in Malaysia, but I think it's going to happen in the next 12, 24 months. There are more and more agents, and there's quite a wide range of. So people are trying different types of antibodies, which can carry something with it. So there are also other agents that there's other chimeric antibodies. So there are a lot of fancy new drugs which are being carried along by one drug.
Right. Doctor, there's one, I think if you're okay to take one last question.
Yep, sure.
Okay, Doctor, there's one on, if it is difficult to repair the DNA in the double chain using the PARP inhibitor, what are other options that we have?
Okay, so if you look at the picture I showed earlier, let me just quickly show it to you.
Yeah, I think that might be helpful, Doctor.
Yeah. Hang on, sorry. So in PARP inhibition, if you look at this picture I'm showing you here, what PARP does is it repairs single-stranded breaks. You see on the left side, the green part, it repairs single-stranded breaks. PARP does not have any major role in double-stranded breaks. So PARP, single-stranded breaks, homologous recombinant repair, or HRR, double-stranded breaks. So in normal cells, if the HRR, the bottom part, if it's proficient, i.e. those patients who do not have BRCA1 or 2 mutation, it can repair double-stranded break. So generally speaking, PARP inhibitors not so useful in this, but there are exceptions to the rule. So what happens is we're exploiting this fact that BRCA has very little capacity to repair double-stranded breaks. But what we are doing is actually inhibiting PARP, which causes more single-stranded breaks not to be repaired. And when it's not repaired, if another mutation happens, then it becomes a double-stranded break. So PARP doesn't play a major role in double-stranded breaks. One is double-stranded breaks. We need homologous recombinant repair. Just to clarify with it.
Yeah, sure, no problem. Thank you so much, Doctor. Doctor, so I think very quickly, just kind of summarize. I think one of the important messages that you're sharing with us today, I think, is that one, there's a lot of new variations, new treatments to deal with advanced stage disease. So it's not about stopping, and then when you've got a late diagnosis, I think the idea is not to stop and sit at home or get concerned. There are many options. And I think one of the more important things that you're also telling us is not all cancers are the same.
Yeah.
Even if they are of the same kind of physical or anatomical type. They're really very individualized, and actually you're opening up a very exciting new world for us of personalized therapy, and it gets more and more personalized.
Absolutely.
So your treatment will have your name on it, Doctor.
Absolutely.
So,
yeah.
Doctor, if I could kindly ask you to, share with us maybe one or two things that you want us to take away from this session.
I think that there's a lot of very good clinicians, scientists all over the world working very hard. But what happens in cancer care is we're moving ahead very quickly with testing. So make sure you come, don't give up, come get tested and get on with the right treatment. If you can't be on the right treatment because of cost, and certainly that's one of the part of the equation, please, if you can, participate or get yourself, if you are eligible, into a clinical trial. Clinical trial drugs and all the tests, the blood tests, CT scans are all free. You may have to travel to KL, you may have to be in KL, or you have to go to the universities for this treatment. But it's a very useful way both to access expensive drugs, as well as to help take the science of cancer care forward. So what we like to do is promote hope, giving patients more options of having drugs which are personalized to them. And secondly, also to take the science of cancer care forward. And that one of the ways to do that is not only to be treated as an individual patient, but also to encourage people to participate in clinical trials if you're offered a place there.
Right. So thank you so much, Doctor, for sharing those invaluable insights this evening. And this was Dr. Daniel Wong, consultant clinical oncologist at Hospital Pantai Aikro. Thank you very much, Doctor. Good evening.
Thank you.
So, ladies and gentlemen, as I probably should have mentioned, this session is in partnership with Pantai Hospital Aikro, and all three of our eminent speakers this evening our consultants in Pantai Hospital Aikro. And of course, we'd also like to thank Roche Pharma Diagnostics and Shared Services for their support of the entire Cancer and Eye series. Now we're going to move from Dr. Daniel to another very eminent consultant who's very well known in the southern region, and actually, if I could say, a football aficionado, Dr. Shankar Gunarasa. Good evening, Doctor. Thank you so much for joining us this evening.
Yeah, thanks for having me on this talk.
Always a pleasure, Doctor. And Dr. Shankar, for those not in the know, is a consultant colorectal surgeon at Hospital Pantai Aikro. And mostly he's the footballist, as he will tell you. But when he's not, when his interest in passion is actually in colorectal cancer. And Dr. Shankar is here today to talk to us a little bit about a very, very, very sensitive subject for a lot of Malaysians. Basically, our shit, to put it mildly. and Doctor is actually really, I have to ask you, Doctor, why do you want to work in this area every day?
Oh, well, my interest in bowel surgery started way back when I was in undergraduate. I love the elements of bowel, the surgery, the difficulties you get involved, the challenges managing these cases. And now I'm doing more and more laparoscopic colorectal cancer resections, more complex work. So it is a joy, It's a lot of challenging, especially being a surgeon, doing this complex surgery. You always worry about complications. It's part of parcel being a cancer surgeon. Yeah.
Right. Lovely, Doctor. Thank you so much. And actually, I'm just going to immediately turn the stage over to you to speak to us about colorectal cancer and the story of stool. Please, Doctor.
Sure, thank you. Let me share my screen. Okay. So a very good evening to all the viewers on Facebook. First of all, I'd like to thank National Cancer Society of Malaysia and Dr. Muhyiddin for kindly inviting me to have this Facebook live talk. And as you know, this is the month of March, and we are in the Colorectal Cancer Awareness Month. And it's a good platform for me to talk about something about colorectal cancer. But the story I've been tasked to is the story of stool. It's not something you want to talk just before you have a dinner or just after you have a dinner. So yeah, yes, the stool, your friendly stools. The story of the stools, it might give you an indication or picture which might help you or prevent you from getting this colorectal cancer. Yes, stool is very important. And when you talk about stools, when you talk about colorectal cancer, of course, you talk about screening. You need to screen your stools to prevent you from getting colorectal cancer. Okay, since this is a colorectal cancer awareness month, I'd like to bring you to some statistics and data. What are we faced with in terms of colorectal cancer in this country? So if you look through the cancer registry data from 2007 to 2011, colorectal cancer is the second most cancer death in Malaysia. Okay, combining with the male and female. And in men, it is the #1 cancer killer. And cancer colorectal in men, it has superseded lung cancer. And for women, it is the second killer in terms of cancer death after breast cancer. Unfortunately, as we have advanced in our medical treatment and we have progressed and our healthcare system has improved, unfortunately, 65% of our population or patients come at late stage, stage 3 and stage 4. So when you come to a later stage, like what Dr. Daniel has told you, stage 4, the prognosis, the treatment will be very difficult. So the prognosis will be very bad. So what we need to do is to change the stage 3, stage 4 patients coming to the early stages. Why? The earlier you come, the prognosis will be better for you, the treatment outcomes will be better for you. Okay? And these patients coming at the late stage has some impact on the economic burden in the country. Like we've shown from data in 2012, the country spent almost 108 million on new cases for stage 1 to stage 4, forgetting about all the cancer treatment. Just for the diagnosis and treatment of stage 1, stage 4 is for 108 million. This is an economic burden. Most of it come at the very, very late stage. So how can we prevent or educate our population to come early so that we can treat them early, get a better outcome? This is where screening comes in. So you have heard of screening a mammogram for breast cancer. We do have screening for colorectal cancer. Okay, it's a very early stage. Okay, when you talk about screening, is what you see in this picture over here. It is like you're casting a net in a vast ocean, having to pick a few fishes which are positive for cancer. So this is what screening is all about. You need to screen that much of a population to get those numbers positive for cancer. So what is the aim of screening? It's basically to reduce the disease-specific mortality for any disease, in this case for colorectal cancer, and so to improve prognosis with early diagnosis. So the earlier you diagnose this patient, the better it is, the better outcome. That's the idea of having this screening program. So what about screening in Malaysia? Yes, breast cancer screening is very well established in the country, but what about colorectal screening in Malaysia? Okay, so we have started studies, protocols or trials way back in 2010, 2012. And now the country, Malaysia and Ministry of Health has come up with the guidelines of managing a colorectal cancer, which you can see on this diagram, where it's our guidelines, how we manage colorectal cancer, and also what is screening programs in the country. So we have started screening programs in the country since 2014. So what is the rationale of screening? Okay, mind you, like all cancers, your colorectal cancer doesn't develop overnight. You don't wake up one morning and you say, "Oh, I got cancer." No. Colorectal cancer, it is a process. It takes about 5 to 7 years. Something is a small polyp where a lot of your oncogenes, your proto-oncogenes gets involved, go through a lot of mutation, and after probably 5 to 7 years, you develop cancer. So you must understand, you don't develop cancer in few months. No, it is a process. It takes about 5 to 7 years. And that's what screening is all about. Screening is to detect all these patients at the earliest stage so they can catch them early, treat them early, and then give them better prognosis. So in terms of screening, we take them right from the root, the polyps. We do like screening, which I'll talk to you later, colonoscopy. The idea is to identify polyps. Okay, if your polyps are less than 1 centimeter size, okay, fine. The risk of developing cancer is very minimal. Okay, but if your polyps are more than 1 centimeter size, then you have a 10% risk of developing into cancer in 10 years' time. So that is very important. So in this screening colonoscopy, you need to remove these polyps because this will reduce the risk of developing colorectal cancer in about 70 to 90%. So if you have a polyp, and you do a screening colonoscopy, you do a polypectomy, your risk reduction for cancer is almost 70 to 90%. Okay. So, what are the screening programs which we have in Malaysia? Worldwide, we have 2 types of screening programs, which is the organized screening program, which is the population-based screening programs. The other one is opportunistic screening programs. So, what are opportunistic screening programs? This is the program which we have in Malaysia right now, where if you want to go to a healthcare person to get your stool checked, you can get it checked. Okay, it's offered to you, or a doctor offers to you a screening program. This is an opportunity where you go see a doctor, or you come see a doctor and he offers this to you. This is opportunistic screening program, as opposed to a population-based wide screening program. This opportunistic screening program is based on a country's needs and also in terms of budget. So, okay, what are the methods of screening do we have in Malaysia? Okay, we have the common one, the fecal occult blood testing, the FOBT, the sigmoidoscopy screening, colonoscopy, CT scan, and CA. What I'm going to highlight to you now is the first 3, because CT scan is not a modality of screening. It can be used. It can be used as a method of screening, but it is rather expensive. Okay, and CT scans are shown to have to be able to detect polyps more than 1 centimeter its sensitivity is about almost 89%, as opposed to less than more than 6 mm, probably about 82%. The only drawback doing a CT scan is that when you diagnose something on a CT scan, eventually you need to get a colonoscopy done. So yeah, that's the drawback of doing a CT scan as a screening program. It's rather expensive. And CA is not a screening. It is not a screening tool method. It is a protein, carcinoma embryonic entity. It's a protein which is being shared by the tumor cells. It's not ideally used for screening. So the best is the first three. Okay, so when you do risk stratification of colorectal cancer in the country, we always divide them into risk groups so that we can know which needs priority. So basically, if you are a person who less than 40, you're asymptomatic, then you're in the low risk group. And if you're more than 40 asymptomatic, which the vast majority of us are, average risk. And those which are high risk groups are those which have got personal history of polyps, cancer, family history of cancer, or inflammatory bowel disease, or got family history of ovarian, uterine, and ovarian cancers. Okay, so based on our Ministry of Health guidelines on colorectal cancer, the screening for the average population, that means if you're above 40 asymptomatic, the main screening tool based on our guidelines is your FOBT, what is stool or cord blood, the immunochemical blood test, fecal blood test. It's been offered to patients who are 50 to 75 years of age. So if your FOBT is positive, then you need to go for what is a screening colonoscopy. And if it's negative, then you can repeat your stool or cord blood probably in a year or 2 years' time, depending on your risk. Okay. So there are various FOBTs available in our healthcare facilities. The older version, the Guanac is the older version. It is it detects blood in your stools, basically this test. But when you look at Guanac, it detects not only human bloods, it also detects bloods in the meat you eat. Okay, so most of the time when you go for this older fecal cord blood test, you need to fast. That means you can't take meat 3 days before, because if you eat meat, you do the fecal blood test, then it'll be a false positive. Okay, so you need to go through the process of not taking meat for 3 days before going for this blood test, as opposed to the immunochemical and the IFOBT, which is recommended by our ministry and it's also in our guidelines. It is specific for the human blood and for lower GIT bleeding. Okay, it's not influenced by diet or any medications you take, or you just require 1 or 2 samples, which it requires. Okay, and it's got high sensitivity to the older version of Guanac based testing, but of course, it's more expensive. Okay, so we have now the later version of the M2PK fecal cord testing, where it is an enzyme, M2PK pyruvate kinase. It is an enzyme produced in your cancer and your polyp. So what this test does is detect these elements in your stools. If you have positive M2PK, that means you got high sensitivity of colorectal cancers or adenoma. Okay, M2PK has got almost 80% of accuracy in detecting colorectal cancers. So these are the various fecal or blood testing we have in our market here in Malaysia. Okay, so how far have we gone in terms of screening colorectal cancer in Malaysia? We started the screening program since 2014, and they did a review, a 4-year review, 2014 to 2018, and it's the latest paper produced last year from the Ministry of Health together with our colleagues from Alostar. So there are a total of during the 4 years about 127,000 have been screened, and almost what 9% were tested positive for IOBT. And what's more important is colorectal cancer was diagnosed about almost 4% of those tested in those 4 years, and for polyps it was almost 13%, 14%. So this is a very positive outcome for the studies we started doing testing for fecal blood the last 4 years. So this is the flowchart by the Ministry of Health with regards to screening of your stools in terms of screening colorectal cancer. So if you go to health facilities, you go for your stool test, and your result is positive, then you need to go for colonoscopy. Okay, if you're negative, then depending on your risk, you can repeat it after a year, after 2 years. Okay, and if you're positive for your FOBT, then you're referred to a tertiary center to get a colonoscopy done. Okay, and then from there you take on from it. But most often than not, there are a lot of hurdles in terms of screening process, in terms of giving your stools. It's quite, we being Asians, it's a bit of a taboo. And also when you've been diagnosed to have FOBT positive, many of them refuse to go for colonoscopy for the fear of knowing the known. So these are the challenges we have, especially when we want to do screening program in Malaysia. These are challenges we have. That's why we need to have a lot of education, awareness that this is the non-invasive method of getting your screening done for colorectal cancer. So the other method of screening available is your sigmoidoscopy. Okay, sigmoidoscopy, you can see, if I can show my cursor over here. Oh, sorry. You can see my cursor over here. When you do sigmoidoscopy, you are focused on this area of the colon. Okay, so here you do not have any sedation required. You don't need any much bowel preparation. Okay, but sigmoidoscopy has shown to detect and help reduce colorectal cancer of almost about 20 to 30%. The only drawback with colonoscopy is that if you've been diagnosed to have a polyp over this region, then you need to go for completion colonoscopy, because more likely than not, you might be having polyps elsewhere in your colon. So eventually you need to have to go for completion colonoscopy. Okay, the benefits of colonoscopy, which I mentioned earlier in the slides. Okay, studies have shown in the US and Italy, when you do screening colonoscopy and a polyp is detected, it helps reduce your risk of developing cancer to almost from 65% to 90%. It's very good. Based on our Malaysian data, okay, you do a screening colonoscopy, help reduce the incidence to almost 56%. Okay, this data is quite new, and help reduce the death from colorectal cancer to almost 68%. Okay, those who went through screening colonoscopy, the risk of colorectal cancer has been reduced to almost 91% in 10 years. So it's very good. Okay, it's very good. I know there's been a lot of fear of patients going for colonoscopy. It is painful. You've been advised by a lot of people, but actually colonoscopy done properly, it is very painless actually. We give adequate sedation, we give adequate analgesia, and then you slip through to the process. Of course, there is a 0.1% risk of perforation, but it is a safe procedure, colonoscopy. So, what about screening for those who got family history of colorectal cancer? Okay, if you're first degree relative, okay, what is first degree relative? This is your parents, your siblings, okay? You have family history of cancer, or 3 or more that got family history of cancer. Then you need to go for colonoscopy. If your first degree relative were diagnosed to have cancer, say they have been diagnosed, your parents, one of them, diagnosed cancer less than the age of 60 years old, then you need to go for screening colonoscopy as a child 10 years earlier, or at the age of 40, whichever younger comes first. If it's normal, then you need to repeat after 3 to 4 years. These are the moderate risk age group individuals. Okay. Then, if you're more than 60, your first degree have been diagnosed more than 60 years old, then of course you do your screening at the age of 40. Same thing to the higher risk group, which got family history of cancer, syndromic like HNPCC, FAP, Pew-Jeghers, and juvenile polyposis. They are the high risk group of developing cancer, but these polyps eventually in years to come will develop into cancer. So those diagnosed, they need still to do colonoscopy at the age of 40 for the family members. Okay, well, since this is the colorectal Cancer Awareness Month, I like to share this slide to all the audience. What are the symptoms you need to be aware of for you to get yourself investigated? Okay, if you have any of the symptoms, upper rectal bleeding, passing blood in motion, which is not normal. Okay, everyone assumes it is hemorrhoids, but no, you need to get yourself checked. Don't assume any excessive mucoid stools, very mucus, very kanji like mucus in your stools. Go to get yourself checked, screened. Sudden loss of weight or loss of appetite. If you're not on diet, but you seem to be losing weight, your pulse seems to be getting loose, you're losing your appetite, you could get checked. Any abdominal discomfort, any alteration of bowel habits, you need to get yourself checked. Any perineal symptoms, pain, tenesmus, tenesmus is if you want to go to, what is tenesmus? If you want to go to pass a motion, then you don't feel like it, or feel like you're not, like they say, tidak puas. These are symptoms of tenesmus, or unexplained constipation, or when you go for blood tests, anemia, any palpable adrenal mass or endocrine mass. These are the symptoms you need to be aware of. There's something that needs to be checked in your colon. Okay, so get yourself checked. Okay, so in conclusion, in case my last slide, colorectal cancers are in rise in Malaysia based on our statistics. As year goes by, the more and more incidence of colorectal cancer is becoming a burden to us. Early diagnosis leads to better outcomes and prognosis. So get yourself checked so that diagnosed early, you can be treated early and the outcomes better. And colorectal cancer, it is a preventable disease if been detected early. And if you're unsure of your symptoms, you're not sure, run it through with your doctor, because you never walk alone when it comes to colorectal cancer. Okay, and this is me. We have a virtual platform now for you to contact us in Pantai, and you can get in touch with me anytime. And thank you.
Thank you so much, Doctor. That was really very helpful. I noticed we managed to put up the Liverpool logo. For those not in the know, Dr. Shankar is a big Liverpool fan. What is this? Doctor, a couple of questions, and would you be able to take them, Doctor?
Sure. I'll be glad to. Yeah.
Okay, Doctor. There's there's a common question that keeps on cropping up, and I think it's good since we have you to actually kind of debunk this big myth pertaining to colorectal cancer. A lot of people are very hesitant, as you say, to appear when they have colorectal cancer. A lot of people have symptoms, they keep quiet, they don't want to go and test for FOBT. And when you speak to patients, a lot of them are very reluctant to undergo surgery. Doctor, would you be able to share with us, just very quickly, of course, what is the difference between when you come early with colorectal cancer in terms of surgical management and when you come late?
See, when you come for early, obviously a stage 1 colon cancer, the surgery, of course, for any cancer, you need to do a resection. Okay? The resections will be much easier. Your prognosis will be better. Stage 1, you come early. That means your 5-year survival is almost about 90+%. Okay, and if stage 1 and certain stage 2, you don't have to go for chemotherapy. That's for colon cancer. Okay, same thing goes to rectal cancer. If you've been diagnosed early, you can do lots of many non-invasive rectal cancer work if you're a T1 lesion. T1 lesion cancers should come early. You need to do laparoscopy or open. You can even do through your anus. We call TEMIS. You can do like a local resection. It's T1. So the amount of resection, the amount of therapy you have to go with chemotherapy much later, as opposed to stage 1 or stage 2. But stage 3 and stage 4 will be very difficult. Okay, the tumors are big, maybe involving other structures. If you're looking at the colon, say the hepatic fracture, okay, maybe involving your liver, your pancreas, or in the rectum, or just these patients are not amendable, are not resectable at the time. So you need to go to the various neoadjuvant chemotherapy. So it's just in the layman's term, you come later, it becomes more difficult to treat the cancer because you need to go for systemic therapy like chemotherapy later on, as opposed to you are detected earlier. The prognoses are far more better.
Right. Definitely, Doctor. Also, and this is a question that's coming up, Doctor. If I do a colonoscopy, must I, for the next couple of years, should I just continue doing an FOBT as well every year?
If you're doing colonoscopy, no. If you're in the low risk group, no family history, if you do a colonoscopy, then you have to repeat one probably after 10 years, when in the low risk group. But if you're in the high risk group, if the family members has got cancers, your first degree or second degree, and you do colonoscope and you don't have cancer, no polyps, nothing, then you need to do a repeat colonoscope, ideally between 3 to 5 years. It depends on your risk certification. That means you really have to look through your personal history, whether you got any history of polyps before, or your family history, your first degree, your parents, your siblings, or second degree, your grandparents or your aunties. And those are things that come into play.
Right. Will do, Doctor. Doctor, there's also another kind of question that sometimes crops up, and I think it'd be good that we have you to kind of also clarify on this. When you do a colonoscopy, and one of the big advantages that when you pick up a polyps and you actually remove that polyps, which you will, you actually reduce the risk of actually picking up cancer, which is another good reason to do colonoscopies.
Yeah, most definitely, because if you ask me, doing all this, there are various screening programs, sigmoidoscopy, and you do your CT scans, I think when you do a colonoscope, you see a polyp, then you remove it. Like I showed you to data, it's not, if you remove the polyp, you reduce your cancer incidence almost 91% in the next 10 years. So it has shown, data has shown almost 70 to 90% of risk reduction of getting cancer once you do a screening colonoscopy with a polypectomy. It reduces the risk of getting cancers.
Right, and so in that way, it's not only functioning as a diagnostic tool, doctor, it's also a therapeutic kind of, it's also treatment at the same time.
Yes, true.
Excellent. Will do, Doctor. Doctor, you were, and I'm going to wrap this up with this last question. You talked to us a little bit about stool changes, and increasingly there's a lot of people who present with stool changes, and sometimes it's one of the signs of colorectal cancer. What are the things that, and you mentioned this a little bit to us, but maybe better to strengthen it, what are the things that they should be looking for?
Yeah, Modi. See, my stool habits and your stool habits will not be the same. How we defecate is how we've been brought up since young. If you are a person who goes to defecate once a day, every day, that is normal for you. Another person defecates 3 times a week. That is normal for him. You cannot compare another person to another person. But if you defecate once a day, every day since you were small, the last 10 years, then suddenly you see yourself passing motion 2-3 days once, or 4 days once, or once or twice in a week, which is normal. Then there is alteration in your bowel habits. That you need to get checked. Okay. As opposed to someone who goes to defecate twice a week, our patient goes to defecate only twice a week, suddenly see himself defecating every day, which is alteration in his bowel habits. These are the things you need to be aware of. You don't compare yourself with others because your stool habit is totally different from others. You see there's a change in trend of your stool habits, then it is an alteration in your bowel habits, and you need to get it checked.
Right, will do, Doctor. And there's one final question, Doctor, if you're okay to take that.
Sure.
Oh, sure. Doctor, there's one more. So there's, if you have a family history of colorectal cancer, is it good to actually, when one person is diagnosed, to get everybody else to do a colonoscopy?
Yeah, quite surprisingly, no. I had a patient today in my clinic. The wife had cancer last year. I operated on her, and this year her husband had cancer, and I operated on him. Today both of them came to me for follow-up, and the kids were there. So I was telling them, if there are family members who parents who are your first degree have got cancer, if they're less than 60 years old, you need to do your colonoscopy 10 years earlier than what they got. So your parents got cancer at the age of 60, so you need to get your colonoscopy done at the age of 50, or whichever younger, 40 years. So you need to get yourself screened at the age. The minimum age is at 40 years if your parents or one of your parents have got a family history of cancer. Because cancer which runs the family, just like breast cancer, it is a risk factor.
Okay, well do, Doctor. So we're gonna kind of close out this session, and just before we do that, could we have maybe 1 or 2 takeaways from you, especially as you were saying, since this is colorectal cancer awareness month in March, Doctor?
So my advice is, since this is colorectal cancer awareness month, colorectal cancer is on the rise in Malaysia, also in Southeast Asia. It's because the westernization of our diet, of our lifestyle. Okay, we're seeing more and more people are getting cancer. No more the dogma of the older you are, you get cancer. Nowadays, patients who are in their 20s are getting colorectal cancer. So be aware of your bowel symptoms, which I mentioned earlier. If you have any symptoms, any alteration of habits, or any abdominal pain, don't hesitate, don't assume, go see your doctor. Okay, and don't think that colorectal cancer is a disease of the elderly. No more. It's becoming younger and younger in our Malaysian population. Get yourself screened.
Right, will do. Thank you so much, Doctor, for those very thorough and comprehensive insights. And really, I think this is a very apt message to start this month. If you guys, girls, because by the way, colorectal cancer runs very high, both men and female. So really, if take Dr. Shankar's advice, go get your shit checked. If we could, pardon my French. Yeah. Okay. So thank you very much, Doctor. Good evening. We'll see you soon.
Okay, take care. Good night.
Ladies and gentlemen, that was Dr. Shankar Gunarasa, a consultant colorectal surgeon at Hospital Pantai Aikro, who's the second of our speakers this evening in our Cancer and Eye session with Hospital Pantai Aikro. And the last but not least speaker this evening is also very good. Today, like I said, it's all teh tarik session with old friends, and very privileged as well to have Dr. Arivindran Doriraja, who is a consultant gynae oncologist with Pantai Hospital Aikro. Dr. Arvind is also a very good friend of National Cancer Society of Malaysia, the Malacca division, as is Dr. Shankar and Dr. Daniel, as I was telling earlier. And a lot of people will recognize Dr. Arvind as our face for Relay for Life for many years in Malacca. So hi, Dr. Arvind, good evening. How are you?
Good, thank you so much, Dr. Murli. Good evening. How are you too?
We're good. So we just finished talking about stool, and so we're just moving on to the last topic this evening, which is also, I think, a very kind of relevant one. And this is on ovarian cancer, Doctor.
Yes.
And actually, quite a interesting point that I think we recently spoke about on how ovarian cancer seems to be on the rise.
Yeah, it's true. It's true. I think about 4 years ago, among the gynec oncological cancers, cervical cancer was #1 in Malaysia. But since our HPV vaccine and our screening program has taken off, we're seeing now actually it's becoming #3, and ovarian and uterine cancers are going up. So if you can see now, it's the third most common cancer after breast and colorectal.
Right. And I suppose that's the thing. You succeed in one, and we seem to be failing in another. But we will get there, Doctor. And actually, that's very interesting, because one of the reasons why we wanted you to speak about ovarian cancer today was because a lot of focus is on cervical cancer, so people tend to forget the other kind of organs around the gut.
Dr. Murli. Very true. I mean, there's so much hype about cervical cancer, HPV vaccination, pap smears, HPV screening. Nobody really talks about ovarian cancer, and that's why I aptly named it as the silent killer. Because once it comes out, and they usually present very late, and when it presents very late, the morbidity and the mortality is quite high. So I'm glad that we can talk about it tonight.
Lovely, Doctor. So I'm just going to turn the screen over to you and let you kind of share with us a little bit about this silent killer. So hopefully it will not be that silent anymore. Please, Doctor. All yours.
Thank you so much. All right, share my slides. All right. So a very good evening to all the viewers on Facebook. A special thanks to Dr. Murli and the National Cancer Society of Malaysia for this opportunity to speak about ovarian cancer. I think, as I mentioned earlier, that ovarian cancer is something that not many people are aware of and not many people talk about, because I think cervical cancer has always been the hype in the past 5 to 6 years with the vaccine and the screening programs. However, we are seeing more and more cases now of ovarian cancer, and they tend to present very late, and that's why I aptly named it as the silent killer. As you can see in our statistics from 2020, as I said, breast and colorectal are still the highest among the females. However, ovarian has overtook cervical, and uterine cancer is becoming the third most common female cancers in Malaysia at 7.2%, compared to cervix 6.8 and uterine is 5.5. And I can predict in probably the next 3 to 4 years, cervical cancers will further drop and uterine cancers will increase as the obesity pandemic continues. As you can see with this, the summary of statistics, the number of new cases that we see within females is about 25,000. The number of cancer deaths among females are about 14 to 15,000. And you can see the top 5 frequent cancers are breast, colorectal, ovarian, cervical, and followed by uterine. I always tell people that if I have speaking to a room of 100 women, 1 or 2 of y'all will probably get ovarian cancer in your lifetime. That's the lifetime risk of ovarian cancer. Unfortunately, 75% are diagnosed above the age of 55 years old, which the peak incidence is usually about 60 to 65. 5-year survival at an early stage is always good at 90%. However, when they present at stage 3 or stage 4, the survival rate drops, and usually once it's stage 4, they're usually uncurable and palliative, and the survival rate is usually less than 10%. Unfortunately, as in colorectal cancer, 60 to 70% of our cases are actually diagnosed at stage 3 and stage 4. And the age-adjusted survival once you have ovarian cancer is just merely 50%. Ideally, this is what I would love to operate on every day going in. I operate about 150 cases per year, and I think 50% of my cases are ovarian cancers. It would be great if we can operate on this type of patients every day, where they present to us early with this huge ovarian mass. It does not seem to have spread out of the capsule. The uterus is fine, the omentum is fine. However, unfortunately, the reality of it is that out of the 50% of my cases, about 60 to 70% of them will usually present with these kind of pictures where they are very advanced. As you can see, ovarian tumor nodules over the bowel, the omentum, the peritoneum with ascites. This is what we see in the real world day in and day out. Every week, I probably have about 2 or 3 cases of this that comes in where the patients are unoperable. We need to give them neoadjuvant chemotherapy and go in after 3 to 4 cycles. So I'm just going to create some awareness for my talk today about the risk factors of having ovarian cancer. Now the priority or the difficulty in conceiving. So if you, all females who do not have kids, you are at risk of ovarian cancer. Why? Ovarian cancer develops in the ovaries and is due to, as long as the ovary is functioning, it's ovulating every month, it's not getting any rest. So it ovulates, it creates the ovum. Once it repairs, sometimes the mutation or the repair goes in a wrong way, and that's when you get ovarian cancer. So as long as the ovary is constantly working, you are at risk of getting ovarian cancer. If you have a family history of ovarian cancer, whether a mother, or whether auntie or a sister, you're at risk. Early age of menstruation and late menopause are also risk factors because of the prolonged period that you're keeping your ovaries to work. Inherited gene mutation like BRCA, Lynch syndrome also contributes to ovarian cancer. And surprisingly now, a lot of interest has been in endometriosis. I see a lot of women with endometriosis, and I'm based in Sabah, and I see a lot of clear cell cancers arising from endometriosis. So if you have endometriosis, you probably have a 2 to 3% chance of developing ovarian cancer in the future. So I'm very aggressive when I treat endometriosis. The reason why ovarian cancer is a silent killer is because the symptoms are very, very vague. There's no particular symptoms. Abdominal pain, abdominal bloating, early satiety, urinary frequency and urgency, altered bowel habits, abnormal uterine bleeding, they all could be symptoms of ovarian cancers. I will tell you that when these patients come and see me with ovarian cancer, especially those with stage 3 and stage 4 disease, they've probably gone to see 5 other doctors within the last 6 months complaining of these symptoms. They've been treated for gastritis, they've been treated for indigestion, they've been treated for diarrhea, they've been treated for urinary tract infections. And only after 4 to 6 months, when they come and present, someone does a scan or a CT scan, they notice a mass with ascites, that's when they refer them to us. And most of the time, unfortunately, they're usually in the advanced stage. So these are the challenges I face, and I think most gynae oncologists faces when we treat ovarian cancer, because the early stages, they're usually asymptomatic. Usually when you have a cyst, which is about 10 centimeters, usually it does not have any symptoms. As it grows bigger, as it spreads out, as it produces fluid and ascites, that's when they will start presenting to us. Even the symptoms, as I mentioned, are very vague. And currently, I think there's no proper screening tool or any screening program for ovarian cancer. So we're still using an ultrasound and tumor markers basically to make a diagnosis. And I said the challenges is that 60 to 70% present at a late and advanced stage, where surgery and completion surgery, we'll be able to achieve only 50 to 60% of them. And even with the optimal surgery and chemotherapy, most patients, at least about 50 to 60% of them will have recurrence within 2 to 3 years. So can we screen for ovarian cancer? Basically, most studies say no. The latest study was from UK with the UK Tox and UK Fox a couple of years ago. Basically, this was a large multi-center study where they screened women across, and they showed there was no reduction in mortality on the primary analysis. However, they said if you screen for a longer period of time, you might see a reduction in prevalent cases. So if I start screening at the age of 50 for about 100,000 women, by the age of 60, I probably have picked up quite a bit, and I probably could reduce the number of prevalent cases within this group of women. We've got screening tools of a pelvic ultrasound, whether you do a trans-abdominal scan or do a trans-vaginal scan. We do tumor markers. Now, I think most health centers or healthcare that provide women health screening provide this part of screening, tumor markers of a CA1 to 5, your CA, your CA 19.9, and I think your CA 15.3. We've got a lot of algorithms that we use that have been introduced in the UK, like the Roma and Rook algorithm. What we commonly use here in Malaysia is the risk malignancy index. So when a woman comes to us with an ovarian mass, we usually calculate the risk of that mass being cancerous or malignant. Usually we take the menopause age, we usually take the CA1 to 5, and usually we take the scan features and we calculate the risk. Anything more than 200 usually is suspicious of malignancy, and thus is referred to a gynae oncologist or a gynae oncological unit. Can we prevent ovarian cancer? And the answer is no. We definitely can't prevent ovarian cancer because we're still studying where it comes from. However, we know we can reduce the risk. So there was a belief that we now know that most ovarian cancers actually don't arise from the ovaries, but actually arise from the fallopian tubes. So we need to find ways of trying to reduce the risk of them getting ovarian cancer. So as I said, as long as the ovary is constantly working and ovulating every month, it's bound to make a mistake in the repair and bound to grow cancerous cells. So anything that gives the ovaries a break will help reduce the risk of ovarian cancer. So if you have kids, you probably give the ovaries a break for about 9 months to probably about a year or 2. If you start breastfeeding, you also give the ovaries a break. Oral contraceptive pills, which shuts down the ovaries and prevents ovulation, helps reduce the risk. Risk reduction surgery, which I'll talk about, is like bilateral salpingectomy, where we remove the tubes, or bilateral salpingo-oophorectomy is where we remove the tubes and the ovaries. So this is shown to reduce your risk to about 50 to 60% of developing ovarian cancer. So I'm just going to quickly, briefly talk about the current trends in the management of ovarian cancer. So as gynae oncologists, we are moving towards more ultra-radical surgery because it's been proven that if you have ovarian cancer, especially those with advanced disease, the only thing that will increase your chance of overall survival or giving you a time of complete remission is getting every single tumor out of the body, everything microscopic single tumor out of the body. So what we are trying to achieve is optimal cytoreduction. So whatever tumor cells that we can see with the naked eye, we try to remove. So we tend to go towards ultra radical surgery where we just don't remove the womb and the ovarian tumor, but we remove the lymph nodes that are bulky, we remove the omentum, the appendix. Sometimes we need to do a splenectomy. Sometimes we need to resect the liver. Sometimes we need to remove the peritoneal surface of the abdomen. Another thing that's been coming up, especially with the Japanese, have shown is dose-dense chemotherapy. Traditionally, chemotherapy is usually given every 3 weeks, but with dose-dense chemotherapy, we cut down the dose and we give it weekly. And this, in a couple of studies, have shown to increase the progression-free survival of these patients, where it means that the patients are in remission for a longer period before they relapse. Another interesting new treatment that's coming out is intraperitoneal chemotherapy. It started off a couple of years ago where the conventional method of giving chemotherapy is intravenously, but now certain studies by Armstrong and cohorts have shown that if you give the chemotherapy into the abdomen after doing surgery, it's supposed to increase your progression-free survival. And what's new and improvised from intraperitoneal chemotherapy is HIPAC, which is heat intraperitoneal chemotherapy, where during the surgery, after you've completely resected all the visible tumor, you basically infuse the abdomen with heated intraperitoneal chemotherapy and leave it there. And this is supposed to also increase, proven to be more efficacious than intraperitoneal chemotherapy. I think Dr. Daniel talked about the new agents of chemotherapy, bevacizumab, which is now used as a first-line and maintenance therapy for ovarian cancers, especially high-grade serous. We've also talked about PARP inhibitors, which are useful in BRCA mutated patients. So these are the few new or current trends that we're practicing in ovarian cancer. But honestly, with all these advancements, we're still losing the battle with ovarian cancer. And the main reason is because these tumors are very aggressive and patients tend to come to us very late. So what I would advocate, and my take-home message is basically prevention is better than cure. We have HPV vaccination for cervical cancers, which is fantastic. We started the program in our schools in 2010, and now basically 10 years later, we can see a decline of cervical cancers. When I started training and now what I'm practicing, I see a much reduced number of cases of cervical cancers, and that too with our pap smear and HPV DNA testing. So for ovarian cancers, to prevent it, we have the risk reduction surgeries, basically a bilateral salpingectomy, a bilateral salpingophorectomy. So whenever anyone goes for a cesarean section and you're planning to tie your tubes, probably you can talk to your obstetrician about removing your tubes rather than just tying them up. If you're having a hysterectomy, and you plan to keep your ovaries, you can always talk to your gynecologist about taking off the tubes while doing the hysterectomy. And if you think you're at high risk of developing ovarian cancer because you have a family history, a mother or auntie of ovarian cancer, then you can talk about removing your ovaries and fallopian tubes as a risk reduction surgery after the age of 40. Apart screening, I think we've only got two modalities of screening, which is the pelvic ultrasound and our tumor markers, which is our CA125, CA, and CA19.9. My personal advice and my personal preference and what I tend to practice is that I would advise any women after the age of 40, once you go for your women's health checkup, is always try to get an ultrasound, pelvic ultrasound scan every year or 2 years when you're doing your women's health checkup, because part of its screening is basically a pelvic ultrasound and tumor markers. And basically it might not help to reduce your mortality, but it will help detect if you have any ovarian mass or suspicious lesion that could be treated early. I run an NGO in Malacca with the Reproductive Health Association of Malacca, where we offer a pelvic ultrasound to women that come to us. And I still do advocate after the age of 50, as part of the women's health checkup, they should get a pelvic ultrasound, including your tumor markers. So I've kept it very brief and concise just to create awareness about ovarian cancer. I would like to thank again the National Cancer Society of Malaysia for having me. If I can, I'm sure you can. And I understand that early detection saves lives. Thank you.
Doctor, thank you so much. Was very enlightening, and I think you shared very important and critical points about ovarian cancer, which I hope our viewers today will kind of imbibe. And I think one of the challenges, Doctor, and I think you put it very rightly, is that there's no screening tool for ovarian cancer.
Unfortunately, we've got guidelines by the Malaysian Cancer Society about pap smears and HPV DNA testing. But for ovarian uterine, there's still not enough evidence to say that every woman should go and get an ultrasound or should go and get a tumor markers. But as I said, I run an NGO and I see more and more women coming for a pelvic ultrasound. I think a lot of hospitals are offering packages about women's health screening, including a mammogram and a pelvic ultrasound. So I think that people understand the importance of it, but there's just no proper guidelines or enough evidence to say that it will actually reduce the mortality or maybe the incidence of ovarian cancer. But I'm still an advocate about screening.
So sorry, doctor, I'm just going to check with you. So let's say we do a pelvic ultrasound, and then or you know when people do actually find an ovarian like a mass, how do they then move forward? Who do they see?
So I see I get a lot of referrals from GPs and other gynecologists where they do a scan and they notice a mass. All right, and then they do a tumor markers and it's slightly raised, and then they refer to it as thinking that it's malignancy. So once they come and see us, we usually assess them. We do a scan, and we kind of have to differentiate between whether the completed family or not completed family, what are the features of the ultrasound. We usually get a CT scan to look at other parts of the body, and then we will decide what kind of surgery she would need. Some of them are very young, from the age of 12 years old. I've got referrals. Some of them are age of 60. So usually when they do a scan, if they have a mass and the tumor markers are raised, or even if they have a mass, they usually refer to a gynecologist. And then when they come to see us, then we do further investigations to decide whether this mass is actually benign or whether it's malignant and what kind of surgery is appropriate for her in her age group.
Right. And I remember Dr. Shankar just now was talking about colonoscopy. And have we kind of got something similar where you put in a camera and then you can see everything that's going on?
I think really we've only got a transabdominal scan and probably a transvaginal scan. That's about how invasive we can go with the pelvic scans. We can't really put in something unless you do a diagnostic scope. But we do have incidences where we've got a mass, we're not sure whether it's malignant. So sometimes we put in a scope through the umbilicus, we take a look around in the pelvis, and you'll be surprised you sometimes find other nodules elsewhere. Then you can do a biopsy to confirm whether it's malignant or not. And if it's malignant, then we proceed. If it's not malignant, then we try to be a bit more conservative. Because another thing that because I work in Sabah, so we see a lot of pelvic tuberculosis presenting like ovarian cancer. So sometimes we try not to be so aggressive in that sense.
Right, doctor. And what is your kind of thoughts, doctor, on people who now think, rightly so, that if I have a very strong history of breast cancer or ovarian cancer, which is driven by like a genetic mutation, should I think about going and getting a kind of a BRCA test done much earlier before I've ever got anything? Does that help? Does that change things?
I think it's a very good question, which we don't really commonly address with our patients. I think the geneticist does that a lot, but I think it's a very important question when we have a patient with ovarian cancer. So when I deal with patients with ovarian cancer, I always take the family history, and if they have daughters, I always counsel them whether they would like the daughters to get tested, because you need to know it's just not about testing. There's a lot of other implications down the road if the mother is tested positive or they are tested positive in terms of insurance, in terms of their family, and whether they should get risk reduction surgery. So I'm an advocate for getting genetic testing, but I think they should be counseled properly by a geneticist or by someone well-trained, because there are a lot of implications. But it actually can save lives, because we have seen patients with BRCA positive and we have done risk reduction surgeries for their daughters and they've gone on to live. So I think it's definitely got a role in terms of risk reduction in ovarian cancer.
Right. Will do, doctor. And so increasingly, that's a conversation which you rightly say people need to start having with their physicians as well. Doctor, there's one more question on what is endometrial biopsy or aspiration? When is this normally done?
All right. Endometrial biopsy is probably not so related to ovarian cancer, but endometrial biopsy is probably more related to uterine cancer. All right. So this is usually normally done when women present with abnormal uterine bleeding. So any woman who presents with abnormal uterine bleeding, that means you have a menstrual cycle, which is about 5 days, and usually you have to use about 3 to 5 pads per day. But suddenly in the last 2-3 months, you've been prolonged spotting for 2 weeks, and then it stops, and in 2 weeks, it's become very irregular. And you're over the age of 40, and you have risk factors for endometrial cancer. These are the people that need an endometrial biopsy. So you can be done in the clinical setting where the patient comes to see a gynecologist. We can just do it in the clinic where we sample part of the uterine lining. And the only reason why we do that is basically we want to rule out uterine cancers, which is also becoming more increasing in our area because of the obesity pandemic. Obesity, diabetes, hypertension are all related to increased risk factors for uterine cancers. So that's why we're seeing also an increase in uterine cancers. So endometrial aspiration, endometrial biopsies are usually done for women over the age of 40 who presents with abnormal uterine bleeding, or if you're less than 40, but you have also risk factors for uterine cancer like nulliparity, diabetes, hypertension, obesity. And with that sample, usually we can diagnose uterine cancer.
Got it. Will do, doctor. And finally, there's one more question. Are you okay for time, doctor? You okay with this?
I'm okay. Good. Thank you, sir. Carry on.
I have a frequent history of ovarian cysts. Does this mean I should get my ovaries removed? Is my risk for cancer much more increased?
All right. It's a very broad question. A lot of people say they have ovarian cysts. It would very depend on your age. It will depend on whether you've completed your family, and it would depend on whether you have a very strong family history of ovarian cancer. And it will also depend on what kind of cysts you have, because we've got lots of kinds of cysts. So usually cysts which are less than 5 centimeters are usually physiological. They're corpus luteal cysts, they're functional cysts, which is normal. They tend to grow and then they shrink, they grow, they shrink. But any cyst more than 5 centimeters, or if the cyst looks abnormal with like solid areas within, those are the cysts that needs to be investigated with further imaging or tumor markers. So if you've got frequent cysts, I think you need to probably get a check with a gynecologist, do a proper scan. They need to look at your age, your parity, and your risk factors. And if you're high risk and the cyst looks suspicious, then it's probably worthwhile getting it removed. But it's just a normal functional cyst that occurs every month with ovulation and all that. It's not a problem. Sometimes oral contraceptive pills for 3 months will help resolve those cysts.
Right. Well done, doctor. And of course, there's this kind of a big, myth around the use of oral contraceptive pills and how they kind of drive ovarian cancer. Okay, would you be able to provide some information on that, doctor?
Right, sure, Dr. Murali. So there are two thoughts. A lot of people talk about oral contraceptive pills, and they are very worried because of the risk of breast cancer. All right, anything hormonal, they're always worried of breast cancer. But in theory, oral contraceptive pills basically reduces your risk of ovarian cancer by 50%. Oral contraceptive pills reduces your risk of uterine cancer by 30%. But you need to consult a gynecologist before starting them. So I've got patients where the mother gets ovarian cancer very young. The daughter is at risk. So just say maybe the daughter, who is probably about 20 years old, gets tested, she's BRCA positive. She's not married. So what do you do? She's at risk of getting ovarian cancer, she's at risk of breast cancer. So sometimes those patients at risk of ovarian cancer, we put them on oral contraceptive pills to help to, as long as I said, as long as you keep the ovaries quiet, not functioning, they're safe. But once you let them function continuously 12 months a year, they are more at risk of developing ovarian cancer. So there's always this myth: ovarian cancer, breast cancer, oral contraceptive pills, breast cancer, oral contraceptive pills, risk of thrombosis. But there's always a belief, and I believe that OCPs have a role in protecting, as I would say, it's chemoprotection against ovarian cancer and uterine cancer. But before you start them on, or especially with the younger generation, you should talk to your gynecologist about it. They should weigh the risk and the benefits of starting an oral contraceptive pills on the young and take it from there. So I don't think oral contraceptive pills are no, it's a bad thing. I really do start them on a lot of young women, and they find it's very good in terms of protection against ovarian cancer.
Right. Well done, doctor. And I think, ladies and gentlemen, the important message to take home is not to kind of pick it up from the local pharmacy and start, based on, I think as with most of these things, nothing is really good or bad in its own right. It's how you use it and how you're guided.
I think there's all the risk and benefits, and by weighing it and speaking to someone who's got the expertise in starting it. Yes, Dr. Murali.
Right. Well, doctors. So as we wind this session to a close, really, I wanted to ask you if you could give us maybe one or two takeaways that would be helpful for everyone who's kind of.
My take-home message is with ovarian cancer, I said if you come in stage, they always come late. So for me, screening, prevention is the best cure. So I would advocate all women out there, get your pap smear, same like how you get your mammograms, do your pelvic ultrasounds, get your tumor markers screened during your women's health checkup. Because if you detect them early, it definitely saves lives. But when we detect them in advanced stage, like stage 3 and stage 4, what we're just doing for you is just controlling the symptoms at that time, probably buy you another 3 to 4 years before it comes back. So we're not winning with ovarian cancer. The only way we can win with ovarian cancer is only if you detect them early. So to all the women out there, please go get your screening done.
Okay, and on those words, we will draw this session to a close this evening. Thank you so much, Doctor. Thank you so much.
Thank you so much, Dr. Murali. Thank you so much.
Time with us. Ladies and gentlemen, this was our Cancer and Eye session with Pantai Hospital Eye Kero, our partners for this evening. And we'd like to thank them very much, as well as Dr. Daniel Wong, Consultant Clinical Oncologist, Dr. Shankar Gunarasa, Consultant Colorectal Surgeon, and Dr. Arivindran Doriraja, Consultant Gynae Oncologist with Pantai Hospital Eye Kero. We'd also like to thank our partners, Roche, Pharma Diagnostics and Shared Services, for kind of supporting us to put this series together. So we look forward to the next installment of Cancer and Eye in line with World Cancer Day, and we will see you all soon. Good night.